Here we have a plain radiograph on 25-year-old with history of trauma comes to emergency department to look for any fractures. There are no fractures, but there is abnormality in the distal aspect of the leg. So how to describe this abnormality and how to infer? So first, the radiological description. There is a fairly well-defined sclerotic area in the distal third of the shaft of the fibula, which is protruding medially. The margins are slightly irregular, but well defined. The zone of transition is abruptly narrow. There is no periosteal reaction. However, the bone is causing compression on the adjacent lateral cortex of the distal third of the tibia, resulting in smooth bone remodeling of the distal tibia. The distal tibia is showing sclerosis along the region of the mass. On the lateral view, the lesion is seen similar and is very well defined. There is no soft tissue component. So this is the radiological description. So based on this, what do we infer? So based on the above abnormality, the findings are most likely to represent a benign bone lesion likely to be long-standing. The findings are most likely to represent or characteristic for a sessile osteochondroma. Differential would include sequelae to previous trauma, resulting in heterotopic ossification or new bone formation along the fibula or intraosseous membrane. So, subsequent MRI was performed and proved to be a sessile osteochondroma. So, the questions which come in viva os is what do you do next in this particular patient? We'll do MRI scan for further characterization and also correlate with any past history of trauma. Few of the questions which might come for Viva or for FRCR2A or MCQ or theory test for radiology are what are the types of osteochondroma? So osteochondromas are classified as sessile and pedunculated. So this one is a sessile osteochondroma. Osteochondromas are can be multiple, in which case it is likely to be diaphyseal achalasis, multiple osteochondromatosis. So this is an autosomal dominant condition where we can find multiple osteochondromas at multiple bones. There is no need to over investigate the patients with osteochondroma. So clinical examination with palpation is advised around the joints such as elbow and knee and wrist joints to see if there are any bony protrusions to make the diagnosis of diaphyseal achalasia, not multiple radiographs as it involves excessive radiation. Osteochondromas rarely undergo osteochondromatous changes, in which case there is change in the symptom or change in the growth of the palpable bony lump. In those cases, MRI is performed to measure the cartilage thickness, and if the cartilage thickness has increased, then the case will be discussed in multidisciplinary team meeting, and subsequent CT guided biopsy is usually undertaken. So, in summary, here is a case of incidental osteochondroma, but despite being incidental, it is of clinical significance because of bone remodeling and compression effect on the adjacent bone. If it is left like this without any treatment or any other further follow-up, there are chances of a pathological fracture of the tibia or early osteoarthritis of the ankle joint. Hence, this patient needs further evaluation with MRI and orthopedic team opinion, and also follow up under orthopedic department if clinically necessary.